Bipolar disorder is a severe and chronic illness characterized by a recurrence of episodes of extreme mood states, such as mania and depression. Patients experience cycling between the mood states, although depression predominates. Altered connectivity within key regions of the brain has been thought to play a significant role in the disorder. Increased connectivity within specific brain regions involved in emotional control, such as the amygdala and ventrolateral prefrontal cortex, has been reported, while reduced connectivity and volume is found in regions linked to cognitive control, such as the dorsomedial prefrontal cortex, hippocampus, and dorsolateral prefrontal cortex. Specific alterations in these brain regions underlie both manic and depressive moods. Furthermore, an imbalance of specific monoamine and amino acid neurotransmitters is also thought to contribute to the mood states. Of these, serotonin has been one of the most extensively studied. An imbalance of specific monoamine and amino acid neurotransmitters is also thought to contribute to the mood states. Of these, serotonin has been one of the most extensively studied. Specifically, depressive symptoms are thought to arise, at least in part, due to deficient serotonin levels. Many current antidepressant medications, such as SSRIs, increase synaptic serotonin by preventing reuptake into the neuron. However, this process can take several weeks to produce an antidepressant effect due to autoreceptor activation, which transiently opposes the immediate effect of SSRIs. Sustained use of traditional antidepressant treatments may increase the risk of a shift to the manic pole of the disorder, which limits their use in bipolar depression specifically. Serotonin binds multiple serotonergic receptors, including 5-HT7, which has been implicated in mood disorders. Blockade has also been shown to induce sleep patterns opposing those observed in patients experiencing depression, and additionally induces rapid hippocampal neurogenesis, an epiphenomenon widely shared by antidepressants. Some current psychiatric medications, specifically some atypical antipsychotics, also demonstrate 5-HT7 blockade, but most of these also possess D2 receptor antagonism, which at high levels of receptor occupancy produces their antipsychotic effect. Manic symptoms observed in bipolar disorder, while dopamine hypoactivity is associated with depressive symptoms. High occupancy levels of D2 blocking agents, therefore, might not contribute in a meaningful way to antidepressant benefits due to substantial postsynaptic inhibition. Targeting presynaptic dopamine D2 receptors has been shown to mediate an antidepressant-like effect by increasing dopamine levels at synapses. Decreased expression levels of another dopamine receptor subtype, D3, has also been observed in depressive moods and is increased by antidepressant treatment. Therefore, a new therapeutic approach targeting serotonergic modulation not subject to autoreceptor-mediated delay of antidepressant effects, combined with presynaptic modulation of D2-D3 receptors to achieve additional antidepressant benefit, may represent an alternative and perhaps enhanced approach to treating the multiple symptom domains in depression associated with bipolar disorder. This novel approach to combine serotonergic and dopaminergic modulation may also be linked to reduced liability for postsynaptic D2 receptor blockade-mediated effects, which may be associated with poor tolerability.
Many people, after discussions like that, really start to recognize the impact of these symptoms, how disabling they can be, The reality is we have made enormous progress in better understanding the neuroscience or the neurobiology of serious mental illness. Bipolar disorder is one of those. Not being motivated, apathy, sleeping too much, no energy. That may look like someone who is lazy, but those are in fact symptoms of depression. And very often, showing a patient or family members a brain scan of someone who's depressed and looking at how different that is in comparison to a brain scan when they're not depressed, I think helps put a little more medical punch to those symptoms so they understand that this is not a sense of being lazy, but in fact a mood disorder with symptoms that are very impairing.
With bipolar disorder is unfortunately suicide. This runs anywhere between 10 to 30% higher than in the general population. So people with bipolar disorder, 10 to 30% higher risk for suicide than general population. Around 20% of all people with bipolar disorder end their lives by suicide, and another 20 to 60%, which is very high, attempt it sometime in their lives. So these are frightening. So there you have it, suicide risk and bipolar disorder. Very serious topics. I'm Dr. Jim, and thank you for spending some time with me.